extracorporeal carbon dioxide removal, or the pumpless extracorporeal lung assist device. So pumpless extracorporeal lung device, in contrast to ECMO, is a pumpless extracorporeal thing, and there is no need for arteriovenous approach since low resistance devices are available which allow sufficient blood flow driven from the patient's own blood pressure. The aim of these device insertions is to support the native lung function and allow the lung protective ventilation, thereby improving the gas exchange. PECLA device achieve a flow rate of 0.5 to 1.5 liters per minute, which is sufficient to allow effective CO2 removal. However, since these are pumpless, a cardiac index greater than 3 liters and a MAP of greater than 70 is considered necessary to overcome the arteriovenous shunt volume. Patient circulation must be able to maintain these requirements, which may require the addition of the catecholamine support. The indications are similar to ECMO. The main indication is hypercapnic respiratory failure, and it has been supported as an alternative to mechanical ventilation in patients with severe COPD and recurrent frequent episodes of acute respiratory failure that fail non-invasive ventilation. It allows protective ventilation with adequate gas exchange, and in the cases of chest deformation, chest trauma, post-surgery, bronchospasm, and asthma. Advantages are avoidance of all pump-related complications. Disadvantages include indirect control of blood flow, low oxygen transfer, arterial cannulation, arteriovenous shunt perfusion, up to 25% of the cardiac output. Contraindications include heart failure, septic shock, low MAP, and severe peripheral arterial occlusive disease. The therapy is terminated when PaO2 is greater than 80 millimeters of mercury and FiO2 is less than 45 for more than 24 hours. Mean support interval has been reported between 7 to 15 days, with a significant improvement in oxygenation, reduction in catecholamine demand, improved MAP, decreased serum lactate, and decrease in the inflammatory mediators. Elimination of CO2 improved the ventilation perfusion matching and has significant impact on outcome of ARDS patient, several for all in the largest centers. So in ECMO, we add the oxygen to the blood and remove CO2 from blood, and a higher flow is needed. ECCO2R is lower flow needed, and CO2 mainly carried out by plasma and linear kinetics without saturation. Indications are ARDS and lung protective ventilation, tidal volume around 6 mL per kg, hypercapnia, raised ICP, right heart failure, immunosuppression, impaired pulmonary epithelial repair, COPD and exacerbation status asthmaticus, and is needed in bridge to transplant. And here you can see the diagram. Membrane lung. So coiled silicone rubber, and in the past with low efficiency and high resistance. Now there's a hollow fiber membrane, microporous polypropylene plasma leak, and non-porous polymethylene pentane PMP, no plasma leak. And this is a diagram to show the membrane lung. These are different devices. Coating to improve the biocompatibility and decrease clotting. These are different devices which are used. So the pump could be centrifugal, diagonal pump, centrifugal plus axial, and various other types. PECLA, as we discussed, Nova Lung, the interventional lung assist membrane ventilator. Hemodynamics should be stable, MAP of over 60 as we discussed. Indications is ALI, ARDS, and bridge to transplantation. Decap allows CO2 removal. Roller pump and hemofilters are used and membrane lung connected in series. Hemolung, there is a centrifugal pump, membrane lung together, rotating core impeller pushing the blood to the surrounding. CO2 removal is effective, blood flow 400 to 500 mL, and gas flow to the membrane lung is under negative pressure. Gas exchange catheter is intravenocaval gas exchanger and hollow fiber with membrane lung and intracorporeal catheter in IVC. Gas flow is applied under negative pressure and high complication rate is there. Dynamic intravascular lung assist device, rotating fibers, modified Hotter catheter, CO2 exchange further improved by the covalent immobilization of carbonic anhydrase to the surface of membrane fibers. Respiratory dialysis, using the dialysis to remove CO2 from bicarbonate, easy to remove bicarb but difficult to maintain pH. There is a rapid conversion of CO2 back to bicarbonates. Electrolytes, hemolysis, and cardiac arrhythmias may occur and is still under the investigational stage. Thank you very much.